This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Dr. Anita Federici. Dr. Anita Federici is a clinical psychologist and the owner of the Center for Psychology and Emotional Regulation. She serves an adjunct faculty position at York University and is a distinguished fellow of the Academy for Eating Disorders, AED. Known for her engaging and authentic style of training, Anita has become a highly sought-after consultant. She works extensively with hospitals and community organizations nationally and internationally, offering team training, implementation support, and program development with a special focus on creating differential care pathways for clients who do not respond to traditional treatment approaches. Her work has been presented at international conferences and published in peer-reviewed journals and invited book chapters. Find out more about Dr. Anita Federici in our show notes.
Welcome to Once Shattered, Picking Up the Pieces, Season 4, Episode 138. Integrating Hope and New Pathways to Healing with Dr. Anita Federici. Our guest, Dr. Federici, is an expert on treating people impacted by eating disorders, and she is a passionate change maker in the field of mental health. We are so excited to have her with us today, and she will be joining us in just a moment. But first, I'd love to introduce my best friend, my husband, my soulmate, Jack Major.
Hello, Linda. Great to be here again today.
And our dear friend and fellow mental health eating disorder advocate, Ellen Bennett.
Welcome, listeners. And remember, the links for Dr. Anita Federici and your hosts are in the show notes.
Okay, so I have a quote today, and I've always thought this quote was by Albert Einstein, but I guess there's some controversy over it. Some people said Benjamin Franklin said it, and some people said nobody said it, but I'm going to use it anyway. My quote is, "Insanity is doing the same thing over and over again and expecting different results."
And I've said that many times over the last few years.
We are so excited to welcome our most respected, dedicated, and compassionate guest, joining us from Canada, Dr. Anita Federici. Welcome.
Well, hello.
Welcome, Anita. This is so exciting to have you and this morning and talk more about what you're doing. You have some incredible initiatives that are going on. So welcome.
Thank you.
Yeah, welcome. I have looked forward to this for about 2 years now, from the first time that I connected with you after I saw one of your talks at the AED 2 years ago. And so welcome and thank you for agreeing to do this podcast with us.
Well, I feel just as honored. It's really my pleasure to be sitting in this space with you. So thank you so much for including me in these important conversations.
Okay, well, put on your seatbelt. We're ready to go. So you said we can call you Anita, right? So
please call me Anita.
Okay.
Yes.
Anita, can you share some of your backstory and why you wanted to become a clinical psychologist?
Yeah, I was actually recently on a panel when this question was asked to me, and I did this thing, and I thought, okay, so there's the thing that I tell everybody for the last 25, 30 years, which is, you know, I love learning, I love academics, I love being in school, I love trying to, and I'm so passionate about mental health. And so those two things collided over time through my master's degree, through placements. I got a placement in an eating disorders program, and I completely fell in love. I felt like I was where I should be. Felt like that was what made sense. The other part of the story is the part that you could never say, for 25 years because it wasn't safe, which is, that I have my own lived experience, right? And so that was not safe professionally, personally, to do that. But I can't separate. Like when people say to me, why do you do this? It feels disingenuous for me to say, I don't know, I just liked eating disorder work, so I did that. So it's both personal and professional, but I can't imagine being anywhere else.
Well, I think that gives professionals so much more clout with their patients to know that the person really gets it and has been there and has experienced it on some level too. So I think it's powerful, and I'm glad that people, if they're comfortable sharing, can do that now.
Yeah, I think we're meeting more and more people in the field now, young people who've been through it, been through the journey, and they understand. Yeah. And it does. It just makes that connection with the patient so much more real, and as opposed to just all clinical and out of a book.
So you love working with eating disorder patients. So that was your motivation, right? Because you had some experience and as a professional. Yep. And you also have an affinity for working with patients with suicidal ideation as well.
Mm-hmm. Yeah.
And go ahead. Yeah.
No.
Does your scope of practice focus just on those two areas, or is it broader as well?
It's broader, like many people I think would recognize today. But when I started in the eating disorders field, in the early 2000s, everything was very siloed. You would go to eating disorder treatment, and if you had any other co-occurring condition that quote unquote interfered with said eating disorder treatment, you were asked to leave, told to leave, or the patients themselves just felt like it was such a poor fit that they themselves would leave. They would be told to go somewhere else. Well, go to the trauma program to deal with your trauma. Go to the OCD program to deal with your OCD. Go to people that work in suicide and self-injury to go do that. But of course, and I can see you all nodding, you know where I'm going with this, which is that of course, when you go to those other programs look at you and say, well, we're not an eating disorder program. So we can't treat your trauma and not touch your eating disorder. And so as I moved through my own training, I could not separate these things. It seemed unethical. It was very confusing to me that we would be removing people from treatment because of co-occurring substance use, because of co-occurring suicide. But all of my efforts to integrate treatments that could benefit patients from those perspectives were all, frankly, they were just not allowed. They were just not allowed. And that journey, my interest in that took me into the DBT, dialectical behaviors therapy. I worked at the Center for Addiction and Mental Health. It wasn't an eating disorders program, but I went and worked there. And DBT just made so much more sense to me. And I know we'll talk more about that. And that was really the collision of eating disorders and then working with co-occurring other things simultaneously, compassionately. And that's what DBT allowed me to do and bring to the field of eating disorders.
Yeah. Eating disorders never stand alone. And, we certainly saw that with our own daughter who, had some substance use problems and couldn't get treated for that because of eating disorders, and couldn't get treated for the eating disorder because of the other problems.
That's right.
It's terrible.
That's
absolutely
right.
Terrible. So you mentioned DBT. So can you give us a brief overview of what CBT stands for and DBT and how effective they are? Yeah.
In brief, CBT stands for cognitive behavior therapy. It is probably the most widely used, what they call evidence-based treatment, even within the eating disorders field. So CBT is considered a frontline treatment approach for people with eating disorders. It's used across levels of care. And the focus in CBT is on changing what are labeled as maladaptive thoughts, assumptions, beliefs, behaviors that drive and maintain eating disorders. And so this is where you get things like food exposure, body image exposure work, challenging eating disorder thoughts, all really very important work, very, very necessary work. About 50% of people respond to CBT. 50% of people with eating disorders respond. In the adolescent world, you have something called FBT, family-based treatment, just to sort of, so if you've got someone under the age of 18, you're probably going to be referred to FBT first. FBT, is a treatment that focuses on empowering the parents to feed their child and then gradually return control of eating over to the child. Again, 50-60% of families respond long-term to something like FBT. So we know that those treatments are important. I would never want to get rid of those treatments because they do work for a number of people and families, and they do not work for everybody.
Yeah.
And so we know that people who have co-occurring conditions tend not to do as well in CBT. We know that people that struggle with emotions and relational dysregulation, they tend not to do so well in CBT. We know that people that have co-occurring suicide and self-injury require a different kind of treatment. So this was the birth of what we call MED-DBT. So DBT, dialectical behavior therapy, is a comprehensive multimodal treatment that was started by Marsha Linehan back in the 1980s and 90s to treat chronic suicidal and self-injurious behavior. That's really what she was trying to do. What's remarkable to me is that Marsha Linehan took an illness, what is called borderline personality disorder, an illness that was labeled treatment resistant. And she transformed that to say, actually, if you do DBT as it's done, 60-70% of those people don't even meet diagnostic criteria for borderline personality disorder. So she took an illness that the field had said, you really can't do anything with these folks, and said, actually, you can when you treat them differently. And that is sort of, I feel like that is just in my whole approach to working with people. I don't believe that people can't get better. I believe that people need different care. So DBT focuses on emotion regulation. It focuses on relational regulation. And it's designed to treat multiple problem behaviors simultaneously.
So when you talk about the success rate for CBT for people with eating disorders, is it similar for people that have substance use disorders?
Is CBT has similar effectiveness rates?
Yes.
It's interesting. I would say I haven't looked exactly at that in a while. My experience would be that you are going to always have a certain type of person that is going to respond to cognitive behavior therapy. It's a good approach. And then there's always going to be people based on their temperament, their personality, their emotional life, that they're going to need more or different treatments. You have to also, in the substance use world, there's also just more differential treatments, right? People access AA, they access NA. There's just a different pathway that people have access to when there's substance use that we don't do in eating disorders.
It always amazed me that evidence-based treatment, and everybody agrees, works at best 50% of the time. And that's good enough. I don't think that's good enough. 50% is not good enough.
Yeah,
so
we'd still be in high school.
yeah, 50%. Yeah. Right.
If we're lucky,
we wouldn't have passed.
Right.
Yeah. So you've had success with patients who did not respond well to other therapies, and using MED-DBT. So can you share how that MED-DBT is different and how effective that is? I think I've read about this, and I think it's so remarkable that you're going down this other pathway.
Thank you. So I first would talk about what it stands for. So it's MED, it's multi-diagnostic or multi-problem eating disorder. So that's what that stands for. And we added the MED to it for a couple of reasons. One, to signal that it's not the same as standard dialectical behavior therapy. So if you seek out dialectical behavior therapy from someone not trained in eating disorders, you're not going to get the same treatment. So this is an adaptation of DBT for people with long-standing, usually, eating disorders that have not responded to the frontline approaches. It's also important to highlight that there are other researchers that have looked at applying DBT to eating disorders. So a lot of places will say, well, we're adding DBT skills into our day treatment program, or we're, things like that. That to me is a very different type of DBT adaptation for eating disorders. MED-DBT is minimally a 6-month program that focuses on building a life worth living. So, which is an interesting frame, right? So the eating disorder gets targeted within that, but the emphasis is on a life enhancement rather than just an emphasis on medical stability or weight gain. So for a lot of our clients, ambivalence is significant. Emotion dysregulation is substantial. So asking them to gain weight, they can go do that. They can go to a program, gain weight, and come out and still not know how to manage anything. Mm-hmm. This is about teaching people how to build a life that they see as worth living. And the interesting thing is that most people want to do that. Most people say, gosh, I'd love that. I'd love to have a life that feels meaningful and satisfying and that I don't feel like I'm in threat mode all the time. Would love that. I don't think I've ever had somebody say to me, no, thanks. Right?
Yeah.
I am just like, wow.
Right? I'm looking at you.
Wow. Yeah. I can't, because Linda, Jack, and I always say they forgot who they were. They didn't realize.
And they don't
that life could get better.
Exactly. Yeah. And they don't have, they're so separated from everything, and it's all about the illness that they don't necessarily want to go back to that. So I think this is just so refreshing.
Yeah, I mean,
and
they've had
positive.
They're adults now. I mean, they've been doing this now. So
that's right.
They're late 20s, 30s, whatever, and they've had everything taken away from them. They said they went to college, they graduated, they got a job. They may have got married, had families, and then these illnesses just took all that away, and
there's no purpose.
There's no purpose for them, and then to just throw them back into these treatment centers with the same old that they go through over and over again. It goes back to the insanity definition again.
It does.
And then they are still further removed from the life of their connections. I mean, there's just more distance. So this is.
Well, and I also think by that point, they've experienced some trauma and treatment. And so they are so impacted and really need a different focus and framework to work towards.
Yeah.
Yeah.
Yeah. I mean, this is.
Yeah.
Go ahead.
I was just thinking about, that overemphasis on the medical view of the illness and the minimization of quality of life, whereas in MED-DBT, that is the driver. And so it's the why, why should you stop purging? Why should you gain weight? That's not enough to say, well, because you have an eating disorder, especially when those elements of recovery are not experienced as having a life worth living. Like a lot of my clients, will say, well, I've recovered into a larger body. This doesn't feel like a life worth living to me. Whereas in MED-DBT, we are constantly looking at what does it mean to have both? What does it mean to live in a weight-centric diet culture environment and change your body? What does that really mean? So there's a lot more, philosophical discussion around these things. And another big element, it's interesting you mentioned sort of trauma within the system, invalidation within the system is so pervasive. I'm so grateful for my colleagues who are writing about this more and getting published, because it still is, I think, pretty widely denied. Like, I think a lot of programs would say, oh, we don't do that, but I see it all the time. MED-DBT is rooted in what's called the biosocial theory, which is that a person absolutely makes sense when you understand their unique biotemperament and you understand the ways in which their learning has happened and the invalidating environments that have shaped who they are in that moment. And so in MED, we are also targeting the invalidating environment explicitly, which our clients love.
Yes.
Love.
Oh my gosh.
Yes. Yes.
So, yeah, I mean, we met so many young people now who, there's always the people that say, oh, they're treatment resistant. They're not treatment resistant. It's a failure of the treatment. And I don't want to throw all these treatment centers under the bus. I mean, they're necessary and needed so much, but they need to start listening to the patients and
when you hear so many people saying the exact same thing,
I know,
how can you not pay attention to that?
I know it's very subjective by these patients, but when you hear the exact same thing, and again, I don't know if they do surveys like that because they only want positive comments probably.
And these are people that will also say good things about aspects of their programs that were very helpful, but there's certain things. It's a punitive factor too. But
even when you saying 6 months, it is addressing that it takes time. Yeah. When you're this far in the depths, it's not a quick fix. And I think that in itself is such an important message that, Yeah,
I know. We could talk about this for.
Oh, do we need to move on to other questions?
I know we do.
What?
So I think I know the answer to this, but I'm going to ask you because are medical providers embracing this MED-DBT therapeutic approach?
So I've been at this. Our first publication was 2012. Dr. Lucine Wisniewski was writing about this before then. And I was at a conference, I think it was AED 2 years ago. A keynote speaker said something like, it takes about 17 years for early work, for new ideas to actually permeate. And I feel like well, here I am, pretty much, 10 years in, 12 years in. And I feel like now there's more interest. So I spend most of my time at this point in my career training other programs and teams internationally. And all I train them on is MED-DBT, which makes my heart really happy because, and this is from adolescent to adult. So we have an adolescent version and an adult version across levels of care. And in fact, I just started a MED-DBT listserv for clinicians who are trained in the model so we can work together. So I have 85 people. I just started this a few weeks ago. I have 85 people from Singapore to Australia and New Zealand to Mexico, United States, Canada, who are absolutely on board, trained, trying to figure out how to make this more available. That said, there's still a lot of pushback for MED-DBT or just DBT in general. So I'm often feeling like I'm that salmon swimming upstream. I think that I do receive a lot of pushback from colleagues from programs who say this isn't evidence-based, who say this is too expensive.
Come back in 20 years. Right.
Yeah.
Well, if we don't try these new things, they'll never be evidence-based. So,
you got to be open.
Well, and then you have to think ethically. But even ethically, if we have a treatment, like DBT is very evidence-based. It's one of the most evidence-based treatments for emotion dysregulation, suicide, self-injury, anger, relational distress. All of my clients experience those things. So that minimally is evidence-based. Mm-hmm. And we're bringing in evidence-based eating disorder knowledge. So that's evidence-based. And I have people that contact me from all over the world looking for this treatment. So ethically, if we say, oh, well, we just can't offer it to you, that becomes an ethical dilemma as well. When there is a treatment that has some effectiveness data and people want it, and then we're going to choose to withhold it from people.
Yeah.
I don't believe that meets ethical standards.
Yeah.
Oh my God. And when you think we continue to have a 20% mortality rate, and this directly, when you talk to people like us, it directly addresses that because it's another option. It's an expanded practice to treat that's so refreshing. I am just like, bubbling over here like there's hope, there's change, there's good stuff.
There's definitely that. And MED starts off as more harm reduction, and that makes a lot of people uncomfortable. Except that when you think about who you're working with, these are people that need help with ambivalence. Some of them struggle with insight and all kinds of things. You need space. Like my first ask of my clients is, are you willing to stay alive, at least while we work together?
Yeah.
That's great.
I don't know what you're going to do in 6 months from now or a year from now. I don't know. Let's worry about that then. But look, I don't have a chance in hell of helping you get to that life worth living if you're dead.
Right.
So shoot, minimally, could we agree? So what this does is people go, well, that's not unreasonable. Because and so that means it keeps us out of hospital. It keeps us medically stable. It keeps us away from suicide and self-injury. And then we build there.
And they want to live.
Going in, they do want to live.
Go ahead.
Yeah.
Oh, I love this conversation so much. Oh my God. Okay. I am really curious about a little bit more information on differential care pathways. If you'll tell us a little bit more about that. As we walk this path, we have certainly realized that patients often struggle, treatment, relapse, refuse care, or difficult time following a plan, and the list goes on. How does differential care pathways impact recovery and patient response to treatment?
Differential care pathways refers to the idea that there's not one way to do something.
How novel. How novel.
I know.
Yes.
The confetti's falling from the ceiling.
Yay.
See, this is the thing that I find so fascinating. Right? It's like we sit here and we go, that's so obvious. And it's not the experience on the ground. Right? So on the ground, that's to me the paradox of it all. Like we sit here and we go, well, of course, why would all people respond to one or two treatments? I mean, that makes no sense. Yeah. And yet those are the guidelines that rule, and that's what gets funded. And so what happens is that if you're an adolescent, it's FBT, and if you're an adult, it's CBTE.
Yeah.
That's it. And if those don't work on an outpatient basis, then you're referred to higher levels of care. And those higher levels of care are very different in what approaches they use. I wouldn't say that most of them are not adherent to any one of those things, right? Most of them are working on helping someone get nutritionally stable and get medically stable. And there could be a mishmash of things going on in there, but, And so there's very few, it's very narrow. I would say that the options for people seeking treatment and care in eating disorders is very narrow. Yeah. So that's great if you're someone that responds to FBT, and that's great if you are someone that responds to CBT. You can get those. Certainly in Canada, we've seen an increase in publicly funded services, so that's wonderful. Mm-hmm. Boy, if you're one of the 50% of people that doesn't work.
Hey,
you really don't have to. So differential care pathways for me are having streams available for people with different types of presentations and different needs.
You mentioned FBT, and I know it's evidence-based and it works in a lot of families, but when you have an adult who's now in their 30s or late 30s and they're beyond, and they're coming out of a treatment center, and they're contracted to do family-based therapy with their families, wonderful families, absolutely wonderful, loving parents, everybody's supportive, but they've been dealing with this for now 20, 30 years, and you've got an adult who's again, there's enough shame and stigma with the disease, and now, they've got their parents spoon feeding them, basically, with a meal plan and stuff, and it just, it just adds more to that shame of. And
it's a lot on the parents.
It's a lot, on the parents who,
they've got to be such the heavy.
Who are working, they're working parents most times. They've got other children, and
that's right.
And I find sometimes
their own health,
right?
Yeah.
And I find sometimes that adult patients are protective of their parents. They don't want them to see everything, and that's part of the disease probably, and part of the pride. Part of their pride.
Well, they have a little bit of a streak of independence.
Yeah. A little bit. Yeah. So I don't know what the answer is. I wish there was more places for people to go, when they get out of treatment, to go to some place where people who have been through the journey themselves are there to help them, with the meals, and do it slowly, because so many of these people say, some of these caloric intakes they have to do are very traumatic for them, and when they tell me about it would be traumatic for me to eat some of this stuff.
Yeah.
So,
It's, I think community is incredibly important. Whether that's like, there's some adult folks I've had the pleasure of working with, and their family, it just works out, and it's a way of moving forward for a period of time. And many others that just don't have the support that they need. Like, it's just unrealistic to put too much more on a family, and the patient still needs support and community. I really do believe. And the nice thing about online communities is that, you're able to connect with some really incredible people who are doing some incredible stuff. Mm-hmm. And I think we're just going to see more of that. So I think we have to get creative, but that's part of, even in MED-DBT, that's what we do. Like, building a life worth living almost always means who are your people?
Yeah.
Right. Who's helping you, supports you? Where are they? And sort of working against loneliness and isolation. And
this
those
is
sorts
such
of
a great
things.
conversation. And I want to we have to keep moving along here, but I want to know, how is mental health care different in Canada from the United States?
In a lot of ways, but probably the one that shocked me the most. So I worked in Cleveland, Ohio for several years. And what shocked me was that I was able to get treatment for my clients in MED-DBT for 6 months, if not longer, covered by insurance.
Wow.
I can't do that in Canada. So that was very shocking to me coming from Canada. I thought, it's going to be even harder in the US. I was able to treat far more people in the clinic I worked in under an insurance covered plan.
How is it coded? We need to know. What was the code?
I have to go. It's been, I haven't been there in a while. I can certainly put you in touch with my colleagues who are there and doing this work. But I remember spending time on calls with the insurance agents and, in network, these sorts of things, and speaking to them about the behavioral nature of these disorders and how they work and how they fit their criteria. And, also showing that these are people that often cycle in and out of very high levels of care. So they end up costing a lot more money. We're not really seeing outcomes. They're not really getting back to their lives. And so we were far more successful. I would also say that healthcare, my experience of healthcare in the United States was that there's just much more, there's many more treatment options. There's a lot of red tape in Canada around what you can do and what you can't do. My experience in the US is that there's a business mentality. People open intensive outpatient programs. People do they just make it happen. For me, it would take me 2 years to do some of what's going on over there because of government policy and things that I'm allowed to do or not allowed to do. That said, we do have a number of government funded services. So you can get FBT, CBTE, day treatment, all covered. And almost none of them do DBT. Okay. So again, you can keep getting those treatments, but you can't get. I just had a client the other day who was sent to one of our largest Ontario-based hospitals. They are mandated to treat people with severe, long-standing eating disorders. They turned the client away. Client's medically unstable, really needs help, because they said she was too high risk because she has suicidal thinking and self-harm behavior. That is an outrageous thing to me.
Yeah.
But this is the fourth time in 2 weeks I've had that happen.
Yeah. We've run across people when we were in Washington last year who are saying that psychiatrists are dropping people because they're, if their patient's suicidal, they're afraid they're going to get sued if they die under the
and
their watch.
therapists as well.
That's crazy. That's crazy. So I know we could go on for hours. We should have her for a whole day here. So change.org is a website that allows people to create and sign petitions for social change. And I know in 2019, you got a petition going called "My Patient is Dying and Why We Can't Access Treatment." And I have it on my phone here, and you wrote, "Imagine for a moment that your child was diagnosed with a life-threatening medical condition. You were told about the following things about the condition. 1 in 10 will die. Suicide is the second leading cause of death after cardiac failure. For those that live, life expectancy will be shortened by 20 to 25 years. And there's more and more things here. And, incredibly, you were looking for 25,000 signatures, and so far there's 24,475.
As of a week ago.
So would you please expand on this and perhaps read more about it?
Thank you for bringing attention to that. That was before COVID. And, it almost feels like Groundhog Day. Like we're sitting here having this conversation with you. It feels like I was having this conversation 5 years ago and 10 years ago. And it was a client that I was working with who was just rejected from treatments. And because she had co-occurring things going on. And she really wanted treatment. My gosh. And I was so frustrated that I just wrote it one night. I didn't think anything would come of it. It was my own. I was so disheartened. And then what happened was this outpouring, this, hey, me too. Yeah. I had goosebumps. And so here it is. It's years later, and my patient is this patient that started this in my head. She's okay. She's doing well. But it's everybody. It's not just her. It's this 50% or whatever you want to call it. It's so many people who need more support and more voices. And the only way we're going to get change is if we have more voices behind this. Yeah. That's it.
Yeah, we said that all along. I mean, our stories aren't unique. Emily and Katie's, story lost their battle, and there's people, every 52 minutes, somebody's losing the battle,
and it's probably so much higher. And it's probably
more because of those statistics. And I hate statistics because every number is a person who's gone way too soon, a family who's forever changed. And so, I hate those statistics, but they're real. And some people still don't know, that people die from eating disorders. They still think it's just all about the food. So, and in this article, I see that the wait time for funded treatment can be 6 to 12 months, in Canada.
That was before COVID.
Yeah. So it's worse now.
Worse now.
Yeah.
Yeah.
Okay.
It can be anywhere from 2 to 4 years.
So, 2 to 4 years. Oh my Lord.
In some locations and in some.
Yeah.
Yeah.
So what we're trying to do with our grassroots organizations and all these talks is bring more families, more stories out there of people, not just people that have lost children, but people in the system who are frustrated, clinicians that are frustrated, and everybody just shout from the rooftops that these changes have to happen.
That's a great idea. We'll all get on our rooftops.
Shout from the rooftops.
Yeah.
We're shouting.
Be a good
We're
social
shouting.
media post.
Can people still sign that petition?
Oh, I just did.
Okay,
Yeah, you can.
So you know what,
can.
listeners, sign this petition because you need about 525 more signatures.
Yeah, whether you're in Canada, the United States, wherever you are, sign the petition.
It doesn't matter.
Doesn't matter where you are in the world. Sign the petition.
Change.org, and it's titled "My Patient is Dying and We Can't Access Treatment."
Yeah.
I was looking at your website, which I encourage everyone to check out. Your comprehensive team approach is inspiring and brings me so much hope that change is going to happen. By design, you demonstrate that mental health issues are complex and multidimensional. Tell us about your belief. All people want to get better. It's such a beautiful, compassionate approach, and I think it can truly reshape the conversation.
I think that what you believe and the assumptions that you hold as a therapist, as a clinician, as a parent makes a huge difference in how you respond to people. Marsha Linehan, this is one of her assumptions. It's not mine. If you're a DBTer, right? One of the things that you agree to is the belief, the assumption that everybody wants to improve. Because the minute that you think that somebody does not want to get better, and I hear this a lot in mental health and in eating disorders, they like the eating disorder, they like the sick role, they're not really motivated. I don't buy any of that. So for me, and I've said this before, I have never met a person who did not want to improve. I've never met that person. I am referred people all the time with the note, this person probably doesn't want to do anything. This person doesn't want to get better. And I meet people who sometimes in the beginning say, I don't want to do this. But I think they're telling me something different than I don't ever want to improve. I think people want to feel safe. I think people want to have a life that is satisfying and meaningful. And I think that we have to explore what improve means. So that's not just my definition of improve. It's yours and our definition. But I don't believe that people want to be in a suffering threat state as a way of being in the world.
No.
I'm almost 25 years into this. I've never met that person. And I can speak from lived experience as well. Even in my darkest days, I was always still looking for it, hope or something. Something's got it. You don't really want to die. Mm-hmm. You just don't know. You just don't know how it's going to look different because you've never seen it.
Mm-hmm.
Or you've forgotten, right? Or you're so far in the depths that you've lost all those connections. And sometimes I think we forget that with individuals with mental health and including eating disorders, that depth is, and they just need a guide. They need that light.
They just can't see the light themselves. So they need somebody to help them find the way.
Yeah, they've been told by, so many people who've given up on them, and it's like they don't matter, and they need to know that they matter. And that's,
And the world is going on pretty much without them because of the isolation.
And the person that they gave up on them doesn't even know what's happened to them after the fact, that they've moved on to somebody else and somebody else and somebody else. And it's...
I think it's just so essential, so important, eating disorders and across that, because the minute that you've got co-occurring other things, then I feel like the judgments and the stigma is even compounded. Yeah. And I've just watched I've sat on too many teams where the team is judgmental. I've sat on too many meetings where the view of a patient's behavior is very pejorative. which is another thing I like about MED-DBT. There is a heavy focus on the clinician. What is the clinician thinking? How is the clinician treatment interfering? How is the clinician speaking non-judgmentally? And the focus, so we have to put ourselves on the board each week to be exploring what are we doing that might be actually interfering with the treatment. That is not done in standard eating disorder care. And I think it's a major blind spot.
Yeah.
Okay. I think that's great. So the current treatment, we all agree, of individuals with eating disorders and those with other mental health conditions needs to be revamped because so many are falling through the chasms in our current system. As a clinical psychologist and the owner of Center for Psychology and Emotion Regulation, you are doing this. Tell us about the center, the clients you work with, and the trainings you offer for medical professionals.
I never intended to start the clinic, the center. It's one of those things. I thought I would just have a little office in a space by myself and do the best that I could because I moved north into a rural area. And then the clinic just grew and grew and grew. And it's turned into this space that I feel incredibly proud of. So there's about 26 of us. We specialize, I like to say, we specialize in, if you have ever felt misunderstood and misdiagnosed and undertreated, we're your people. I feel like that's where we shine.
That's why you grew so fast, because there were so many people.
I think so. I think so. I think people really resonate with that. And that's certainly been my experience, is that there's too much invalidation. And so everything for me is rooted in how to create validating spaces that, and deeply have significant training and understanding in what does it mean to have an eating disorder, but what does it mean to have other things? So we treat co-occurring difficulties in the context of an eating disorder. We have a trauma track. We have a mood and anxiety track. We have a DBT track. So we have those differential care pathways. And so my team does a lot of that heavy lifting at this point, because a lot of what I do is training, consultation. So I do a lot of MED-DBT training. I'm actually, with Lucine Wisniewski, we are almost done the MED-DBT book. So that will be published in 2025. Yes. So I spend a lot of time right now writing and trying to influence the systems through my training and advocacy and getting myself at conferences and having exactly these conversations. Right?
Wonderful.
So bless you.
That's a lesson in fulfill.
Bless you for being who you are and what you're doing.
Thank you.
Okay, we're winding down. Last question. Just you saying that you're writing a book, talking about the training that you're doing, gives me so much hope. And as we look ahead in the next 5 to 10 years, what do you see? What is this landscape going to look like? Are people really around the world going to embrace multiple pathways so that people really access the treatment they need? It's shocking in this conversation today that we haven't broadened that concept to be more flexible and meet everybody's needs where they are.
Yeah. I would say that we are in the midst of that transition happening. And it's really uncomfortable right now. I often liken the eating disorder field right now to being in an earthquake. The ground is shaking, everything we thought we knew is all being questioned. And earthquakes freak people out. So you got a lot of polarization in the field right now. People are uncomfortable. People are scared. They don't know what to do. I do believe, though, that with any earthquakes also unearth parts of the ground that you didn't see. And that's what I'm seeing. I saw this a lot at the conference this year at ICID in New York. Much more lived experience representation, much more space to look at different ways of seeing an issue. I do think we're going to see much more inclusion, much more diversity. And it's not going to be fast enough for a lot of people now who need it like now.
Or yesterday. Yeah. Yeah.
Oh, wow.
Yeah, for sure.
Anita, I know you have a Zoom right after this, so we're running out of time. Very quickly, is there anything? Well, first of all, can you tell people where they can reach you, and then add anything that you'd like to leave us with?
People can reach me. I mean, I'm on social media. I try to stay on my Instagram. I try to respond to everybody. I love my little Instagram community. It's not huge, but it's a really awesome group of people. And so that's a great way to connect with me. And I try to post as much as I can about what I'm doing there. So, I try to share research that I think speaks to the things we've talked about today. So that's probably the best way to reach me. And I really think that this is the kind of work, what you are doing, talking to people, elevating voices, not being silent. The worst thing we can do is stay quiet. That complicit, that's sort of a complicit way of reinforces the eating disorder itself. I think our strongest way forward is together and continuing to have these conversations and not being afraid and shaped out of them.
Yeah.
Wow, this has been absolutely amazing. Thank you so, so much for joining us today. Ellen and Jack feel the same way.
Oh my gosh. Again, I wish we didn't have time constraints and we could just continue this.
I know. We have 10 topics.
Anytime.
We'll have you back.
Anytime. I would love to.
That's great.
I would love to. Thank you so much for inviting me. And again, for your experience, I was so glad to connect with you online. I'm so glad you reached out. This feels very meaningful for me. And I look forward to continuing to have conversations with you in different places and different ways. Thank you so much for what you're doing.
Well, we're going to see you in person at some point.
We got to renew our passports or get those enhanced licenses to get to Canada, but we're not that far away. So, yeah.
Yes.
Thank you for all you're doing.
All right. So thank you, Dr. Anita Federici. And thank you, listeners. Our daughters and you are the reason we do this podcast. And a warm thank you to RockFox Recording and Production and Scott Fitzgerald, sound engineer extraordinaire, for expertly producing our podcast and so much more.
Help us continue the conversation. Please rate, review, share, and subscribe to Once Shattered, Picking Up the Pieces on the platform you are listening to us on. Tell your family and friends about us, and check out the show notes to learn more about Dr. Anita Federici, as well as Linda Jack and their book, Emily, the Story of a Girl and Her Family, Hijacked by Anorexia, and their nonprofit, the Emily Connection.
And also learn more about our wonderful, wonderful co-host Ellen Bennett and her nonprofit, K&B for Answers, in honor of her daughter, Katie. And please remember how important these conversations are, because everybody's mental health matters. And if you're looking for a place to record your podcast, record your audiobook, or do a legacy cast for your loved one, please, the only choice is RockFox Recordings and Productions for doing those wonderful, wonderful gifts for people. And thank you, everybody, for listening. See you next time.